Hi, my name's Ian Davis. I'm chair of ANZUP Cancer Trials Group, and I'm speaking to you from the ANZUP Annual Scientific Meeting held in Brisbane in July 2019. And it's a great pleasure today to talk with Professor David Quinn, medical oncologist at the University of Southern California, and an Australian forever, no matter where he lives. So, David, great to have you here. Thanks for coming to the meeting.
Thank you, Ian. Great to see you and great to be here.
David, 2019 has been a really busy year for prostate cancer, and it would be easy to forget that there are other gender urinary cancers that are of interest to ANZUP and the people watching this video. You've got an interest in kidney cancer, and quite a bit has been happening in that in the last few years, and particularly this year as well. Could you give us your thoughts about where the current state of play is for that?
Sure. I think we've had a standard and first-line metastatic renal cancer of a VEGF receptor TKI for years, based upon the approval of sunitinib now 15 years ago. And that's changed. In the last 2 years, we've had the mantle of sunitinib and other similar drugs that have been equivalent, such as pazopanib, questioned initially by the Cabo-Sun trial, randomized phase 2 study run by the Alliance, where cabozantinib had a superior PFS and response rate in intermediate and poor risk metastatic patients.
So what effect do you think that has had on management in 2019 and beyond?
Well, I think there's been some uptake of cabozantinib in the first line for intermediate and poor risk patients, particularly those with bone metastases where cabozantinib seems to have an advantage. So from that perspective, a minor change. But then what came after that was the advent of first-line immunotherapy in the form of Checkmate 214, where we saw nivolumab and ipilimumab produce a response rate and overall survival advantage over sunitinib for, once again, intermediate and poor risk patients. So we've had that in the United States for a couple of years. It's now available in most parts of the world, including Australia. And I think it's been a game changer in terms of overall survival for those patients that can tolerate it. So I think that's a big difference. And then the data that's come in 2019 have been with two combinations of VEGF TKIs with immuno-oncology drugs. The biggest impact that we saw was the combination of pembrolizumab with axitinib versus sunitinib, where in a very early analysis, at about 12 months follow-up, we saw an OS advantage with a hazard ratio of 0.53. So a big effect, but in addition, that is also mainly in patients with intermediate and poor risk cancer. And the hazard ratios in the favorable risk, they still overlap 1, and they probably won't make me change my practice. About the same time, we saw data from the Javelin study, which once again had sunitinib as a control arm, and compared that therapy to a combination of avelumab, a PD-L1 inhibitor, with also axitinib. And it showed a response rate that favored the new experimental combination arm, and also PFS that was heavily in favor of the new combination, but we don't have overall survival yet. Interestingly, in that study, the PFS, including in favorable risk, did favor the new combination of avelumab and axitinib. So we've got some things that are going to question the balance. And of course, on the two newer studies, very brief follow-up, 12 months in one, about 11 months in Javelin, and then a further interim where we don't have a lot of details, and another one to come. So we're going to get more data, but I suspect that these combinations are going to be available in the rest of the world, and they will have turned first-line therapy on its head.
So then what do we do? If someone has progressed through ipilimumab and nivolumab, or a TKI and a PD-1 targeted therapy, and then progress, what are we going to offer those patients?
Well, I think that the truth is that if you follow level 1 evidence, we have no idea. But I think that most of us would look at giving some form of VEGF TKI after nivolumab, ipilimumab. And the two choices there are typically cabozantinib, where we have good level 1 evidence with overall survival advantage, albeit over everolimus, from the Meteor trial for using cabozantinib. So cabozantinib might be one answer. And then the other evidence base, which goes right back to the Axis study, is with axitinib as a single agent, which we have a lot of experience with and maybe one of the better tolerated TKIs. So What becomes more complicated is if you've got a VEGF and IO combination, what do you give after that? Well, you may resort to cabozantinib, but you also may resort to some of the other VEGF TKIs, depending on what you think the tolerability is going to be in those patients. And then there's a question of whether you should, if a patient progresses on IO and VEGF, whether you might give a combination of nivolumab and ipilimumab later. And we're starting to get some data to suggest we can see a response.
Retreatment approach.
A retreatment.
Yeah.
Now, that's expensive outside of most guidelines and is probably not going to meet approval in, say, Australia and New Zealand, at least anytime soon. But I think this is a time when renal cancer therapeutics, in terms of what we select and the sequence of our therapy, has been turned on its head.
We should say, for anyone watching from Australia, at the time we're recording this in July 2019, we can't yet use cabozantinib on our reimbursement scheme straight after ipilimumab, nivolumab. There has to be another TKI in between. So that's not the case in other parts of the world.
Well, in that setting, I don't have a problem with people picking something else, and probably my first choice would be axitinib, which I think is available in that setting in Australia, but not in New Zealand, where they have to fund it themselves.
Great. Okay. So what do you think is the next big question we should be asking in renal cell carcinoma?
So I think there's a sequencing question. I think that we need to get longer follow-up on some of these studies, and we're going to see some Me Too studies, if you like. The CLEAR study, which looks at pembrolizumab and lenvatinib, another VEGF TKI, compared to sunitinib, will be coming. And also we have combinations of cabozantinib with nivolumab in the first line that I think are going to be interesting, and we'll see whether they can produce the PFS response and overall survival data that we've seen. So we're going to be inundated with data in the first line. I think we have some novel therapies that target, for example, HEF2 and some of the metabolic pathways that are important in renal cell coming, but they're still in early phase 2 studies at the moment. So to the point where we will have to do a phase 3 study is interesting. And I think we also need to look at some alternatives. So one particular study I think is very, very interesting is one that you're running at ANZUP, which is the KeyPad study, which looks at after initial VEGF TKI, which is still a standard first-line therapy for a large number of patients, giving them pembrolizumab and denosumab, where there's a theoretical advantage of the rank ligand inhibitor in combination with PD-1 inhibition. So I think that's an important study. So I think the bottom line is, while we're learning, we need to keep doing these studies and accruing to them. And ANZUP's a great vehicle for doing that.
Thanks, David. So I think that takeaway message that there's still a lot of opportunities, but there's still a lot to learn, and the best way to do that is through clinical trials. So David, thank you very much for your time and for your support of ANZUP.
Thank you very much, Ian.